So as we know, we've got a lot of challenges with regards to our health these days, particularly with COVID, coming out of lockdown. And there were a lot of challenges both before COVID and that have been made worse by COVID. And we have perennial problems around preventing disease and improving health in the UK. And we also know that it's going to be really important for us to build sustainable and resilient communities in the future. And in part, in order to be able to cope with and prepare for and react to the future crises that are happening, are going to be happening. So whether they're epidemic, the second wave or third wave, economic, financial, social, environmental, ecological, we know there's quite a lot of things happening, and things are going to be bubbling away, I think, at a even faster speed. So we know trials are great at actually producing evidence as to what might cause what might impact on what. So it's always very interesting to see if you can conduct randomized controlled trials to try and establish causality and try and create strong evidence as to what the best methods are to cope with these challenges. So the standard approach to trials, we know historically has been over the last 40, 50 years, has been a standalone approach where we have one single trial. It's a standalone trial, and we know that these are often very challenging, slow and costly, and general recruitment is really, really challenging. At the moment, I think we've got up to just 50% of trials, publicly funded trials, managing to recruit to time and target. Trials are very often underpowered, and they investigate a small number of hypotheses over a very short time frame, whereas we know many of our questions, actually, we want to know not just what's going to happen if we do this now, but what's going to happen in 5 years' time on the impact of obesity or diabetes or immunity, for example. We know that our standard system for designing and conducting trials is financially and scientifically inefficient. So over the last 10 years, there's been some really nice, interesting, innovative solutions to how we design and conduct these trials. And these have been situated in, well, there's been lots of interesting improvements. And one of the most exciting, I think, is around using or creating new infrastructures and data collection systems to facilitate multiple trials. So rather than being standalone trials, we use existing systems or create new systems to collect data to facilitate multiple trials. So I'll talk a little bit more about these. So we've got quite a lot of trials which now are embedded within existing data collection structures that use registries, electronic health records, administrative databases, and platforms in order to identify and recruit people and or collect data and outcomes. So just looking at platform trials, which is probably the cutting edge with regards to innovation in trial design in some senses, certainly in certain arenas. A landscape analysis by Parks in 2019 identified 83 master protocols, but 99% of these involved experimental drugs, and 92% of these platform trials were embedded in oncology. So basically, it's mostly pharmaceutical drug trials, either here or in the States, and mainly in the field of oncology. We also know that we can use longitudinal epidemiological cohorts, i.e. groups of people who we follow up over time, and we can embed multiple trials within these structures. So the one that I was really interested in for my PhD was trials within cohorts, which we published in the BMJ in 2010. So that design is also taking off. So there's at least 80 studies in different parts of the UK, Canada, and other parts of the world, which use this approach to where you embed multiple trials within a single infrastructure that recruits people and also collects data. And the applications there of this particular approach are much more varied. Now, excitingly, here at Queen Mary, we've got the first trial within a cohort for the COVID era. So Professor Aidan Martineau and the rest of the team, including myself, have managed to get this very exciting study up and running. So a great speed. So this has been going, I think, almost 5 weeks now, and has recruited over 8,000 people. So the idea is to create a confidence cohort in the UK. Anybody in the UK is eligible to take part. So if you haven't taken part already, I would encourage you to do so. And then people, when they join, they fill in a questionnaire which takes between 25 and 45 minutes to fill in. And in order to be part of that cohort, they have to give consent for their to be contacted again, for their data to be used for future trials, to be approached, to be invited to take part in trials if they're selected to be in the experimental intervention group, but also to have their health data, the data that they give for the confidence cohort, or to be linked to routine data. So there's quite a big ask really in terms of what people are asked to do. So this study hasn't yet received NIHR funding. It's just a small amount of Bart's charity funding, but already it's recruited 8,000 people. But ideally, it should be recruiting millions. So that would be really fantastic. So the next approach is actually combining both A and B. So A, embedding with trials within existing data collection structures, and B, embedding trials within longitudinal epidemiological cohorts. And so if we combine structures A and B, we get what we're calling a mega cohort. Well, isn't that rather ambitious? Well, yes, but actually the Australians are doing it. So Generation Victoria is a really exciting new study. It's got about 50 million Australian dollars and an amazing team of people in Australia who are launching Generation Victoria. As from the beginning of next year, they're going to be recruiting every child born in Victoria and the parents, both parents of every child. This is going to create a very large cohort for research that benefits human health in Australia, and they're going to be blending data collected especially for the Generation Victoria study, but also they're going to be linking it as well to existing data, health data. They're going to be able to integrate multiple trials within this single mega cohort. And trials within the Gen V, that is what they're calling it, they're designing it so that actually the trials that are embedded within Gen V can use a whole variety of different consent approaches. So opting in, opting out, waiver of consent preceding randomization, or a TWIX patient-centered staged approach where you stage the information and you tell it in the way as you would in routine care, or you don't tell people about treatments they're not then going to get. So also within Gen V, they're also talking about trials. They're also, what they're setting up is the potential for trials to be conducted alongside Gen V, but then using data from Gen V. So this will be particularly suited to trials arising from electronic health records and external registries. So a really exciting study. So if you want to find out more about that, there's some publications coming out soon, and have a look at their website. So, but whatever structure you create for your trial, whether it's a standalone or embedded within a particular structure or multiple structures, you've still got to get the people. You've still got to find your population and collect information from them in a timely way. So whatever study, we all know this, don't we? So it's a challenge. So how do we address this challenge? So exciting work around making trials more efficient by embedding them within existing structures, allowing different types of consent procedures, etc. But how do we engage the target population and make sure that all our trials recruit to time and to target and recruit representative populations, regardless of what population the trial is being conducted in? So as we know, many people have spent a lot of time and a lot of money and a lot of energy trying to make this happen. So the CRN, the Clinical Research Networks, the NIH are involved. So look there, they define public involvement in research as being carried out with or by members rather than to, about, or for. It's a very important distinction. And then most recently, be part of research, which is a sort of dating agency really for people, the members of the public who want to get involved in health and social care research that's taking place across the UK. And then this, which is the latest evolution and this impetus to get everybody involved in research is a new NIHR Centre for Engagement and Dissemination, headed up by Jeremy Taylor. So that was actually launched on April the 1st this year, in the middle of COVID. And I'll talk a little bit more about that in a minute. So thinking about recruitment. So I've been designing and helping people with trials for over a decade now. And it's always been a sort of conundrum. Why don't people take part in trials? But then you think, well, why should people take part in trials? And then thinking about it from sort of standing back, it seems to me, it seems obvious really that we're asking people to become involved in systems which actually inherently constrain or silence their voice. So if you think of all that data that's out there, all the data, these are 250 different organisations within the NHS that collect data, HDR UK, etc. It's all about the data on patients who seek treatment. So in order for your, as a citizen, in order for your data to be made visible, you need to actually go and seek treatment. And when you seek treatment in primary care, you get 7 minutes. You're asked to only talk about one condition. Data from that during and after that consultation is entered by a clinician who's often paid 3 or 4 times the average national salary. It's entered into a black screen. You don't see what the data is. You don't know what it is, and you don't know where it goes. And in terms of the patient voice, traditionally in trials, we use patient-reported outcome measures, and in different types of studies, we say, well, what does the patient report? Not just what does the clinician report, or the system which enables the clinician to deliver the care report. So interestingly, there's so little focus on, from a national perspective, on patient-reported outcome measures. In fact, there's only 2 conditions for which there is nationally reported PROMs. So I think it's hip replacement, surgery, hip replacement and knee replacement. So out of all the conditions, those are the only 2 conditions where we've got national data on the patient voice. So sitting back, we have a health research system and a health data collection system, which is incomprehensible to the average person, and over which few have influence. If people aren't seeking treatment and they want to get involved in research, they have to be proactive, and then they have to be part of research. So these are just sort of standing back and taking a sort of bird's eye view on what's happening here. So what do we need in order to engage people? We need something that's actually interesting to people. Does this interest me? Should I go to this party? Should I take part in this activity? Does it matter if I go? Will my voice be heard? Is there any point in me going? If I go to this party, is anybody going to listen to me talk? Do I trust what happens when I go there? If I speak, am I going to be safe? We need an open, accessible system for recruitment and collecting data. Now, this lovely little phrase, make it simple, make it normal, make it universal, is the new strapline that Jeremy Taylor is pushing, who's the new NIHR, well, who is the NIHR Director for the Public Voice, and he's also the Director of the NIHR Centre for Engagement and Dissemination. So he's saying this is what needs to happen with, recruitment, doesn't it, really? So a mega cohort, if they can do it in Australia, can we do it here? And can we do it so that we actually produce data that is timely? So interestingly, we were all watching over the last few months, 6 o'clock in the evening, when the Downing Street was making the announcements about what we were supposed to be doing or not doing, or covering or not covering, or touching or not touching, and what money we would or wouldn't be getting. There was the data that was mainly reported was data on what was happening in hospitals, on deaths. So that was the data that was reported, and then some data on possible diagnoses. And I kept on waiting for, well, how's the UK public? We're all at risk, all 65.5 million of us. How are we? We're all undergoing this massive national experiment, this huge piece of research. But what is actually happening to the public? And so I kept on waiting for some data on how people were, but I haven't actually seen it yet, not in a systematic way. There's lots of innovation, of course, from many, many researchers, including lots at Queen Mary who've been going and listening and collecting and reporting data. But there hasn't been any national systematic reporting of the public voice. So the rather the blue sky thinking we've been doing, the rather ambitious idea is to actually have a mega cohort for research that benefits human health here in the UK, that blends data collected from the UK National Health Study with linked data where possible, integrates multiple trials within this mega cohort. Trials, again, of course, similar to the previous models, can use different approaches, opt-in, opt-out, etc., in terms of consent. And also trials can be conducted alongside and dip into and utilise the data collected from the UK National Health Study, this mega cohort. So the idea is a mega cohort plus 4 ideas to increase saliency, accessibility and trust. Those barriers to us taking part, the people in the UK taking part in research. So the first idea is the idea of multiple entry points. Rather than just being one long questionnaire or short questionnaire which people fill in, that actually there's different surveys, direct to public, about a range of topics, overlapping probably some of them, all interconnected, that will be salient to different people. So some people will be really interested in unemployment, finance, domestic violence, mental health, viruses, diabetes, food. So these are all really important areas that we need to be collecting information on and designing and conducting trials at the population level to improve the nation's health. So the idea is, the first idea to increase saliency, accessibility and trust is to have multiple entry points. I'll explain a little bit more about this in a bit. The second idea is to have optional levels of disclosure of personal identifiable data. So people can choose how little or how much they disclose of their personal lives, of their personal data. I'm going to call it data oil, you know, health data being the new oil. How much do they disclose? How much do they share of that to the UK National Health Study? It makes me think of, do you remember those Thursdays, those 10 Thursdays where everybody stood outside their houses and clapped? And I was thinking, wouldn't it be lovely if they spoke as well? So we didn't have the names and addresses and postcodes of all those people, but that they were expressing something really powerful that was really important in terms of what was happening in the UK. So I think it's really important that everybody's able to speak, regardless of whether they want to just remain anonymous or if they're very happy to give lots of their personally identifiable data. Third idea is varying levels of consent. Sometimes people just want to speak and that's it, not be contacted again. And they don't want their data to go any further, but they just want to be heard. Other times people would be very happy to give consent to be recontacted, to consent for their data to be used for randomized controlled trials, to consent for their data to be linked to routine health data, etc., etc. But allow people the option of how much consent they give. Don't constrain it, actually let people choose. And the fourth and possibly most radical idea, and possibly the one that I think would create the strongest fuel to actually generate this, if this ever becomes a reality, is the idea of actually allowing people to have decision-making, allowing people to have power and decision-making control around what happens to their data in terms of who has access to their data, but also what types of interventions are tested as a result of their data, what types of decisions happen as a result of their data. So this is quite radical, and I've no idea how acceptable this will be, and also what level it needs to be. Is this something where perhaps we would need a tripart decision-making process where we would have researchers, policymakers and citizen health assemblies, directors of public health, all gathering together, and each would have a maybe a third or a quarter of the vote around what happens? Or would it, yeah, so how much or how little power different organisations would have in terms of the decision making. But actually just bringing the decision making and the control around the data with regards to how it's used and even possibly what data is collected, actually belonging to a representative sample of people who are citizens. They're not paid experts who've been rattling around in a system for 20 years, paid 3-4 times the national wage. They're ordinary people who ordinary people can identify with. We know citizens' health assemblies are providing some support for issues around how we tackle climate change and environmental degradation. Also, there's some, as a citizens' assembly, recently been operating with regards to health and social care. So, yeah, so that's the fourth idea. So, so I've described some ideas. So how far, have we got anywhere with taking these ideas anywhere? Well, roughly at the same time as COVID struck, we heard news that we had some NIHR funding for an exciting new study called Fresh Street. So this study is testing a place-based household voucher approach to increasing fruit and veg. So basically streets, households, all the households in the streets are randomly offered vouchers for locally supplied fresh fruit and veg. So every household gets a bright green envelope through their front door once a week with 5 vouchers for fresh fruit and veg, which they can exchange with local fruit and veg suppliers, not supermarkets. So the money goes back to the local economy. People are engaged with the local food systems and the local food supply system. So we feasibility tested this idea up in Barnsley and Sheffield last year and the year before with some MRC funding. And so we're very excited to have this study now. So it's going to be a 3.5-year study. It's starting in a month or so up in the north of England, but it's based here at Queen Mary. But we've got this, yeah, and it's going to be tested, this idea is going to be tested in areas. So we're going to be randomizing areas to either have Fresh Street or not. And the areas are going to be chosen according to whether they have low fruit and veg consumption and high deprivation or not. So it's just going to be targeted to those areas with low fruit and veg consumption and high deprivation, which is quite a lot of the UK. We're spoilt for choice, really. But how do we collect information on diet and health from our target population? So we know it's a challenge. We tried really hard during the development feasibility study to actually get people to fill in a health questionnaire, an NIHR, NHS supported health questionnaire called the Yorkshire Health Study, which 77,000 people in Yorkshire had already filled in previously. But in our target areas, even though they said, yes, they would fill it in, they didn't. Talking to local people, what became apparent was actually just a lack of trust around what happens to their data. If they give their data, where does it go? Will it end up with the Department of Employment? And next time that they make a claim for income support, it comes back and that data is used against them. So we found 90% of the population there just would not fill it in, despite wanting to, saying yes, they didn't. So we've been scratching our heads and thinking, well, we've got, a great intervention, we know it's acceptable, but how are we going to collect data on the impact from those households which are going to be receiving it and compare it to those households without? So we thought, well, how about the UK National Health Study? So if everybody in Doncaster and East Riding is asked to fill in the basic questionnaires for our study, so simple 13-question survey on the quality of your diet in terms of frequency, short questionnaires about your health, then we'd have it for all the areas, regardless of whether they were in the trial or not, whether they're in the intervention area or the control group. So we're going to be testing out this idea of the UK National Health Study up in Doncaster and East Riding, which is really exciting, and our NIHR Community Research Facility partners up there are really excited about using that. Also because they're going to be able to use the study to be able to listen to the Doncaster population, regardless of whether or not they're in the study, and also use it to evaluate other interventions that are being delivered. So the second way we've been testing this is we roughly at the beginning of COVID, we also came up with a new outcome measure, it's very new, called VHawk, which stands for Virus Health and Wellbeing Checker. It's a simple tool to listen to patients and the public. Just how is the public? So as I was saying, I was really missing knowing what was happening with the UK public. I wanted to see that data alongside the mortality statistics and the hospital statistics that were being reported every day on the ticker tape on the TV. So it's a patient reported outcome measure. So the patient fills it in, not the clinician or the system. And it asks about virus, upper respiratory tract type symptoms and influenza type symptoms, COVID status, i.e. in terms of the diagnosis, health related quality of life, so that's EQ5D, general health, what types of long-term conditions people have, treatments that people are using and the care being received. And these are not just NHS treatments, but all different types of treatments and care that is being received. So we launched that about 7 weeks ago, 8 weeks ago now. We've got more than 1,000 people who filled it in. So we've got a very small amount of data on the health and well-being of people during COVID, and particularly, and I think some unusual or some interesting information on how people are caring for themselves as well. So the third way we're doing some testing is we've just set up an exciting group of PhD students and undergraduates who are forming a user testing group, and here we're now planning to do some research where we're going to be going to different groups in the UK, in different parts of the UK, including different BME populations, different political groups as well, and exploring the acceptability of the UK National Health Study and Covidence, and also using VHawk as well, and just getting to them to talk about their experiences. We'll be using multiple social platforms in order to collect the data. So that group is just starting up. So that's going to provide some very interesting methodological research, I think, and also help boost recruitment, particularly to Covidence. So the other thing we've done since COVID happened is we've started a new collaboration. It's very small. It's called VHawk, and the purpose of VHawk is to create a group of people and resources to help build healthy health systems. A bit hard to say, isn't it? Healthy health systems. So yeah, that's our goal: building healthy health systems. And our group are wanting to provide the tools, the ideas, the resources to help everybody who's got a health system, whether it's small and micro level and it's a professional organization or a small area, or whether it's a national health system, to help talk to them about ways of engaging the patient voice and providing flexible, providing innovative ideas and resources to help build healthier health systems, so that our health systems don't just collect data, but they learn from that data. This is a concept that's been rattling around. I think it came over originally from the States, so but it's been very, very slow to be taken up in the UK. But it's important. Our health systems can't just remain static. We know this. Pre-COVID, almost every week there was something about the NHS needing more money, too much demand. We know our current publicly funded health system is actually struggling, and we know that actually looking forward for over the next 10, 20 years, we know we need a NHS 2.0, I would call it, a reboot of our publicly funded healthcare system or systems, and we need a flexible approach which actually really does engage and listen to the whole public, not just the treatment seeking, and that actually listens to the public voice. So yes, so in that we've also got one of the tools we're testing is a new health provider platform for real-time data collection and analysis. So that's an interesting new platform. So if you're interested at all, go to VHawk.health. It's still very new. We'd welcome input, criticism, ideas, conversations. So to summarize, so what I presented to you is a potential infrastructure for multiple trials for population health and wellbeing research. It's a mega cohort with 4 rather edgy ideas to increase the saliency, accessibility and trust of people, so that people really do get involved in research, and not just the educated, but everybody really gets involved in research, because it's going to serve all our interests if we do. So these ideas hopefully will remove barriers to recruitment and create a fast and efficient system for generating translatable evidence, so that we can predict, prevent and treat and create policies to improve population health.